Hello everyone, welcome to week 1 of Disorders of Communication. We are going to begin this week by discussing the neuroanatomic basis of speech and language. First and foremost, we need to consider the underlying neurological composition of language. So language can be defined as a shared, rule-governed system of communication, whereas speech is the production of language. I've included this little picture for you guys to try to remember the differences between speech and language because I know that can be confusing sometimes. So just to summarize it, your speech consists of how you produce spoken language, so your voice, articulation, and fluency. That's seen at the top of the little picture. And language consists of form or syntax, so that's what they labeled grammar in the picture. Content or semantics, they labeled that vocabulary, and use, which they labeled pragmatics. So I hope this was helpful for you guys. There are also several components of effective oral communication. These include motor planning, motor programming, and motor execution, which are coordinated with linguistic knowledge and the ability to use that knowledge. So now we're going to talk a little bit about the neurology of speech behavior. Neurons are the cells of the nervous system that transmit electrochemical impulses through fiber tracts, and these impulses allow us to engage in activities. The central nervous system consists of the brain and the spinal cord. Sensory or afferent impulses are transmitted to the brain. Motor or efferent impulses are transmitted from the brain. There's a trick to try to remember afferent versus efferent impulses. So sensory or afferent with an A arrive at the brain, and efferent or motor impulses with an E are exiting the brain. The central nervous system is responsible for coordinating the activity of the entire nervous system. It is protected by bone, the skull, and the vertebral column. The peripheral nervous system consists of the nerves and ganglia outside of the brain and spinal cord. It includes the cranial and the spinal nerves. The role of the peripheral nervous system is to connect the central nervous system with the rest of the body. The primary function of the meninges is to protect the central nervous system. In the picture on the slide, you can see that there's a video. I'm going to post the link in the course so that you can watch it. It's one of a series of 2-minute neuroscience videos, and I feel like they're so helpful in helping you visualize all the structures. The cerebrum is divided into 2 hemispheres by the longitudinal fissure. It contains the cerebral cortex and subcortical structures such as the hippocampus and basal ganglia and olfactory bulb. The hippocampus is a brain structure embedded deep in the temporal lobe of each cerebral cortex. It is an important part of the limbic system, a cortical region that regulates motivation, emotion, learning, and memory. The basal ganglia refers to a group of subcortical nuclei responsible primarily for motor control, as well as other roles such as motor learning, executive function and behaviors, and emotions. Corpus callosum is a band of fibers at the base of the brain that connects the 2 cerebral hemispheres. This is an area of the brain you might hear about if you work with students or patients with seizure disorders. There's a procedure in which they can cut the corpus callosum so that the left and the right brain are no longer connected, and this can stop the seizure activity from traveling from one side of the brain to the other. I actually had a student at my job at Center for Developmental Disabilities who had this procedure done, and it reduced his seizure activity significantly. The arcuate fasciculus connects the important areas for language used in the brain. Broca's area is located in the inferior frontal gyrus, and Wernicke's area is located in the superior temporal gyrus of the brain. We'll speak more about both of these areas later on in the presentation. If you look at the picture in the bottom right-hand corner of the screen, you will see a yellow structure. That is the cerebellum. The cerebellum receives information from the sensory system, such as the spinal cord, and other parts of the brain, and regulates motor movement. It is responsible for coordinating voluntary movement such as posture, balance, coordination, and speech, resulting in smooth and balanced muscular activity. This structure is important for learning motor behaviors. Damage to the cerebellum results in disorders of the coordination of movement. The cerebellum is a highly specialized area, and it attends to regulation of our motor system and the timing and coordination of our movements. The cerebellum helps the cortex to track and correct information regarding posture and activity. Lesions in the cerebellum could result in disturbances of motor planning, for example, tremors associated with voluntary acts and a lack of coordination. The cerebral cortex is the outer layer of neural tissue on the cerebrum of the brain in humans and other mammals. It is separated into two cortices by the longitudinal fissure that divides the cerebrum into the left and right cerebral hemispheres. The cerebral cortex primarily consists of gray matter, which is the bodies of nerve cells, and they conduct nerve impulses. The inner depths of the brain contain mostly white matter, which are the myelinated processes of the nerve cells. The cerebral cortex is connected to lower centers via the vertical tracts. Next, we're going to look at the brainstem. The brainstem is basically an extension of the spinal cord. The brainstem provides the main motor and sensory nerve supply to the face and neck via the cranial nerves. The brainstem contains the pons and the medulla oblongata. Damage to the brainstem often results in dysphagia, or difficulty swallowing. The neural system that controls speech is very complex and it is not completely understood. There are certain principles that we can explore that will help us develop an overview of the neural control of speech. I'll now discuss the principles of lateralization, localization, and contralateral innervation. So lateralization is the establishment of right and left hemisphere preference for different functions. So this holds especially true for right-handed individuals. The left hemisphere of the brain is dominant for many but not all language functions. We do know because of observation that injury to the left hemisphere of the brain is more likely to result in a language impairment than damage to the right hemisphere. However, this does not mean that we should ignore the right hemisphere completely. It appears that the right hemisphere has at least some capacity for language, and in fact may process certain aspects of language better than the left. For example, one possible right hemisphere advantage is the processing of intonation or the melody of speech. Localization is the assignment of a function to a certain area of the brain. Language comprehension and expression have been linked to two major areas of the brain since the 1800s. The area associated with comprehension is Wernicke's area, and the area associated with expression is Broca's area. These areas are named after the physicians who studied patients with language disorders resulting from brain damage. Now I'm going to discuss the third principle written on your slide. Contralateral innervation is the principle that one side of the brain essentially controls the opposite side of the body. In Latin, the word contra means opposite and lateral means side. In other words, the muscles and sensory receptors on the right side of the body are connected primarily to the left half of the brain and vice versa. So people with damaged left brain hemispheres may have a speech disorder and a general weakness on the right side of their bodies. Now that we've finished reviewing the neuroanatomic basis of language, we're going to talk about organic and neurogenic disorders. Etiology is the cause of a disorder. Organic disorders are disorders with an identifiable physical or physiological cause, for example, respiration, hearing, or a neurological cause. Neurogenic speech disorders affect an individual's ability to exchange information. It's impaired due to a nervous system impairment. A neurological disorder is caused by damage to the central nervous system or the peripheral nervous system. Another etiology or cause of a disorder is functional disorders. So functional disorders have no identifiable physical or organic etiology for the anomalies. So as we said before, organic disorders have some physiological basis for their problem. So functional disorders do not have a physical cause. So an example of a functional disorder would just be a child who can't produce certain phonemes in the absence of any physical cause. As I just mentioned, inappropriate tongue placement, that could be a functional speech problem in a child. However, an organic speech problem in a child would be based on a disorder that has a physical nature, such as cleft palate. So a child with a cleft palate speech would be marked with deficits including hypernasality, nasal emissions, and poor production of sounds that depend on intraoral breath pressure, such as stops and fricatives. Issue that becomes an organic disorder. So, if an individual is constantly straining their voice and using other vocally abusive behaviors, that would be a functional problem, a functional misuse of their voice, and that could result in an organic issue, a development of vocal nodules. A syndrome is defined as a pattern of multiple anomalies or malformations that frequently occur together and are genetically related. Because they're related, they have a common known or suspected cause. Craniofacial syndromes involving the head and the face, for example, Down syndrome, cause affected individuals to look alike even when there is no family relationship. So now I just briefly want to go over some concepts that you should be familiar with. So prevalence and incidence. Just to review, prevalence refers to the number of cases of a disease that are present in a particular population at a given time. Incidence refers to the number of new cases that develop in a given period of time. So in our field, we frequently hear people discussing the prevalence and incidence about a particular disorder, autism spectrum disorders. I included this diagram just to help give you guys a visual to explain these concepts to you a little easier. So if you look at what looks like the container, that's supposed to represent our population. Prevalence are the number of cases within the population. Incidents are the number of new cases pouring in the top. You see that with the arrow. And then at the bottom, you see deaths and cures. That's the way you remove yourself from the disorder. Infant mortality is defined as the death of an infant before his or her first birthday. The infant mortality rate is the number of infant deaths per every 1,000 live births. According to the Center for Disease Control, in 2017, the infant mortality rate in the United States was 5.8 deaths per 1,000 live births. Over 22,000 infants died in the United States in 2017. In 2017, the 5 leading causes of infant death were birth defects, preterm birth and low birth weight, maternal pregnancy complications, sudden infant death syndrome or SIDS, and injuries such as suffocation. So the pediatric population is at risk for developing an organic or neurogenic disorder. There are several risk factors that are not limited to prenatal care. So for example, we all know that it's important for mothers to follow certain precautions while they're expecting. We know children should not be exposed to drugs or alcohol while in utero. Mothers are also encouraged to avoid certain foods because we know that they could potentially be putting the baby at risk. Another risk factor is gender. So some disorders or syndromes are more common in males. Gestational age means, in simpler terms, whether the child was carried to full term or not, and if not, what was the child's gestational age at birth. Maternal age, so the optimal maternal age is 25 to 34. And I'm sure that we all know people who have given birth to healthy babies outside of this age group, but just statistically, it's shown that 25 to 34 is the optimal range. Finally, low birth weight is another risk factor, so smaller babies are less likely to thrive. As a speech pathologist, you might end up working in early intervention, and early intervention serves populations from 0 to 3, so it's important for you to get an adequate case history and find out if your child has been in the NICU, ask the mom all the questions about her pregnancy as well. Just to be clear, I know in a lot of your classes, your diagnostic classes, you're going to be probably making your own case history forms, but I just want you to keep all of this stuff in mind when you're making those forms later on. There are reasons why we ask questions such as, what was the child's gestational age at birth? An extensive case history really is such an important tool in order to determine if there are any red flags for a developmental delay. Established risks for developmental delay are medical conditions and anomalies that will result in a disability or developmental delay. These delays can occur due to genetic, neurological, or metabolic categories. An example of a genetic disorder is Fragile X and Down syndrome. A neurological disorder would be traumatic brain injury or cerebral palsy. Seizure disorders can affect cerebral function. I feel like that was a population I didn't really remember hearing a lot about in undergrad or grad school. It was definitely mentioned but didn't go into detail, and I was so surprised by the number of kids I had on my caseload at CDD with seizure disorders. An example of malformation would be cleft palate. An example of metabolic disorder is Hunter syndrome, which is caused by a missing or malfunctioning enzyme. And because the enzyme isn't working properly, it leads to a buildup of harmful molecules in the body. This syndrome is more common in boys. An example of a disorder for the sensory category would be hearing loss. Autism is an example of atypical development disorder. It's a spectrum of disorders that vary in severity. Toxic exposure is another character. So if a child is exposed to drugs or other harmful substances while in utero, there's an established risk for developmental delay. Chronic medical conditions such as cancer, cystic fibrosis, and heart defects also put a child with an established risk for developmental delay, as do infectious diseases such as encephalitis, HIV, and meningitis. So we just spoke about established risks for developmental delays, meaning medical conditions or anomalies that will cause a child to have a developmental delay. Now we'll speak about risk factors. So there are many factors that put a child potentially at risk for developing a disorder. So family history. We know that if there's a family history of stuttering or reading disorders, for example, the child is more likely to be prone to it. Additionally, family crisis could put a child at risk for a developmental delay. He or she may develop selective mutism if they're exposed to traumatic events. Abuse ties right into that. If a child is exposed to traumatic events such as abuse, they could develop selective mutism. Parents who have mental illnesses or intellectual deficiencies could put a child at risk for a communication disorder. Children born to adolescent mothers are at risk for developmental delay or disorder because these children are more likely to receive poor prenatal care and have low birth weight. Prenatal complications are complications that occur before a child is born. So any prenatal complications could put a child at risk. Perinatal complications are complications that occur during birth. So for example, a lack of oxygen during delivery. So a perinatal complication, an example of that would be asphyxia. Premature birth is something that I've mentioned a few times already, so I just figured we should go over that in a little more detail. Prematurity is defined as a child being born on or before 36 weeks gestation. These children typically end up in the NICU or the neonatal intensive care unit of the hospital. This unit is also known as an intensive care nursery, and it specializes in the care of ill or premature newborn babies. The NICU has healthcare providers who have special training and equipment to give the babies the best possible care. These premature newborns are disposed to certain complications, such as respiratory distress syndrome, which is difficulty breathing due to incomplete lung development. These children are often born before they have time to fully develop their lungs, so that's what causes that. And another lung issue is bronchopulmonary dysplasia, which is a decreased lung capacity. Intraventricular hemorrhage is bleeding into the fluid-filled areas or ventricles of the brain. Necrotizing enterocolitis is a devastating disease that affects mostly the intestines of premature infants. So the walls of the intestines are invaded by bacteria, which cause local infection and inflammation that could ultimately destroy the walls of the intestines. Apnea is another issue that's common in premature babies. It's defined as a pause in breathing that lasts longer than 20 seconds. This causes bradycardia, or a drop in the baby's blood oxygen level. Premature babies have immature nervous systems, and they're prone to having episodes of apnea. Because of their immature nervous system, they are also at risk of acquiring an infection after birth, known as late onset infection. These infections that they can develop are partly because of the immature immune system that I just mentioned, and partly because babies who need intensive care may have interventions that make them vulnerable to infection, such as IV lines, frequent blood tests, and intubation tubes. Neonatal sepsis is a blood infection that occurs in an infant younger than 90 days old. Early onset sepsis occurs in the first week of life, and late onset sepsis occurs in week 1 through 3 months of age. So we just talked about pediatric risk factors and prevalence at length. So now I just want to discuss adult prevalence and risk factors. More than 1.5 million adults suffer from a language disability due to a cerebrovascular accident, or CVA. These are more commonly known as strokes. During a CVA, nutrition to the brain is cut off, resulting in damage or a lesion on the brain. These lesions and strokes cause focal brain damage. That means it's to a specific area. We will talk about CVAs at length next week. Another very prevalent issue in the adult community is dementia. Over 10% of individuals over the age of 65 have some form of dementia, and over 80% of individuals over the age of 85 have dementia. Dementia causes more generalized brain damage rather than the focal brain damage we just spoke about with CVAs. Additionally, approximately 2 million people per year have head trauma, and 100,000 of these individuals suffer permanent communication deficits. So head trauma, that's traumatic brain injury you would get from a head trauma. Family history, genetics, and environmental factors all affect the likelihood of an adult acquiring a neurological disability.